So to get to both sides of the argument about a follicle stimulating hormone, I'm going to discuss its components in prostate cancer and actually its emerging role in modulating and possibly causing some of the side effects of androgen deprivation therapy. And rather than taking a pro and con, I've asked the question, is it important? And I'll leave the audience to make that determination at the end of the data presentation. Okay, so those are my disclosures. I'm involved in 2 publications from Harvard Medical School. The one on the right is an annual report for which I receive an honorarium and serve as the editor-in-chief. And the one on the left is a brand new publication that some people in the audience may be interested in. This is a chronological evaluation of approximately 20 to 25 patients that we've cared for over the past 12 to 15 years in terms of seeing how they made determinations about their management of prostate cancer and whether they were happy or sad with it. And that publication is coming out in several months, and I also receive an honorarium for serving on that. And also serve as a consultant to Bayer on a DSMB. Okay, so I'm going to start with a few audience response questions. And the first one is the gonadotropin profile and levels of gonadotropins that result after prostate cancer treatment with LHRH analogs compared to bilateral orchiectomy are similar. Is that a true or a false statement? Okay, so 20% thought it was true and 80% thought it was false. The answer is false, and we can try to encourage some learning on the 20% that did not appreciate that factor. Second question is the gonadotropin profile and levels of gonadotropins the result after prostate cancer treatment with LHRH agonists compared to GnRH antagonists are similar. Is that a true or false statement? Oh, very good. So most of the people realize that there is a difference between the gonadotropin profiles between antagonists and agonists. And my last audience response question, and people get extra credit for this one, is FSH or its receptor have been implicated in the progression of the following cancers: prostate cancer, breast cancer is number 1 is prostate cancer, 2 is breast cancer, 3 is glioblastoma, number 4 is 1 and 2 only, or number 5 is all of the above, which would be 1, 2, and 3. Okay, so, boy, smart audience. 49% said 5, which is the correct answer. You must be reading the most recent issue of Oncogene, so we'll talk about that as well. Okay, so what I'm going to do is to try to provide a historical, and that was the correct answer. It was involved in all 3, and I'll go through that in some detail. So I just want to provide a historical overview of FSH. Its effects on cancer cell lines in prostate and breast have been known really since the 1990s. Dr. Ben Joseph really did some very important work when he was at Wayne State. There are significant kinetic differences in varying forms of androgen deprivation therapy, and I'll talk about the levels of FSH that occur following medical castration versus surgical castration, and it's now being implicated in many of the adverse events that are associated with androgen deprivation therapy. And there's been a renewed interest in the understanding of its biology now that we have the ability to modulate levels of FSH that can be achieved with GnRH antagonists. And I think it's that last bullet that has basically said, are there any differences between various forms of therapy on prostate cancer outcomes based upon looking at levels of FSH? Okay, and this is the comment that Dr. Parton was making. This is, we have the hypothalamus, which stimulates LHRH, that causes the pituitary to release LH and FSH, and there are feedback loops, including inhibin, activin, and follistatin that occur. So obviously when one removes the testicle, there's no feedback inhibition on the pituitary, and FSH levels following bilateral orchiectomy are really quite substantial. And the differences in FSH following either agonist or antagonist therapy will be a focus of this discussion. Okay, so here are the FSH levels on current hormonal therapies. Following bilateral orchiectomy, FSH levels increase substantially. Diethylstilbestrol, very interesting, causes a decrease in FSH levels, and I was just speaking to Dr. Glaudet at the break, and he's got some very interesting data on the use of DES following all sorts of hormonal therapies that cause important tumor regression and PSA responses in his patient population. One wonders whether that's potentially related to FSH. LHRH agonists initially cause an increase. Okay. increase in FSH followed by a decline, and then both with combined androgen blockade as well as with LHRH agonist, there is an escape in which FSH levels sort of come back to normal. And unlike the agonist, GnRH antagonists such as Degarelix or Abarelix causes a permanent and a sudden and precipitous decrease in FSH without going through the stimulatory followed by the decline. It declines really from day one. And here are some data that we did with the initial GnRH antagonist Abarelix, looking at a combination of leuprolide plus bicalutamide, looking at FSH levels in men with prostate cancer. And you can see the increased peak, then a decline. In contrast, a GnRH antagonist such as Abarelix, and these data are virtually identical for Degarelix, causes an immediate decline in FSH therapy. And the thing that we became very interested in, this is the first time with long-acting depot formulations of GnRH antagonist in which we could actually see chronologically the difference in FSH levels between, in the purple line, in the green line, LHRH agonist with or without anti-androgen, with the initial spike, decline, and then a gradual increase. In contrast, GnRH antagonists cause an immediate decline, which is sustained during the period of therapy. And this was the first time that an agent was able to actually persistently and consistently cause a decline to levels not undetectable, but low, very, very low levels of FSH, which had previously been unachievable. And the very interesting thing is that even in patients who are on LHRH agonist therapy, if you orchiectomize them, the FSH levels continue to go up. So it's a very important axis that's maintained. So in prostate cancer, FSH is produced in the prostate as well as other extrapituitary sources, and castrate-resistant metastatic prostate cancer cell lines, when exposed to FSH, causes a stimulation of these cells through its FSH receptor. Other aspects that have been looked at, as I mentioned, Dr. Ben Joseph, who identified the potential role of FSH in prostate cancer, that he mentioned, or he showed that FSH receptors increase as prostate tissues became less differentiated, and FSH stimulates hormonally refractory prostate cancer cell growth in vitro. So these data have been known for quite some time, and we just didn't have any really way of modulating or affecting levels of FSH prior to the identification of the effect that antagonists had. And those are some of the cell data that other peoples have performed. In terms of FSH receptor expression in prostate cancer, the clinical relevance is also seen in tissue samples. FSH receptor is overexpressed in high-grade PIN and progressive stages of prostate cancer. Receptor expression is related to the pathological stage. And receptor overexpression and FSH stimulates prostate cancer proliferation, and then it really implies an important role, at least at the local level, of FSH's effect on prostate cancer and prostate glandular biology. And here are some data from Dr. Sacker looking at FSH receptor immunoreactivity compared to patients with high-grade PIN as well as prostate cancer. And if one takes a look at the T stage associated with FSH receptor immunoreactivity, again, a direct correlation with increased receptor reactivity as a function of the T stage of the prostate cancer. Okay, so those are sort of the preclinical and in vitro models that suggested a role for FSH. I just want to change before we go to the human data on looking at the FSH as a possible explanation for some of the androgen deprivation therapy adverse events. And this was taken from a paper that Dr. Crawford organized with Dr. Marshall and Dr. Shalley that I was able to participate in, basically a round table of people very involved in FSH, really looking at the world's literature of effects of FSH and its potential role in modulating some of these side effects on ADT. And there's the citation just under the title. So if one takes a look at the effect of androgen deprivation therapy, which will be the subject of subsequent talks, on cardiovascular morbidity and mortality, FSH has clear-cut roles in dyslipidemia, plaque disruption, and plaque formation. So whether or not the role of FSH is potentially being modulated as a means of affecting cardiovascular morbidity and mortality is certainly out there. And I think there'll be other discussions tomorrow on cardiovascular roles of androgen deprivation therapy. In terms of the metabolic syndrome that can occur following ADT, FSH has a definite role in adipocyte rearrangement and causing insulin resistance. In terms of bone loss, fractures, and metastatic disease, FSH causes an increase in osteoclast activity, and that's mediated through the rank ligand and TNF-alpha. And in terms of cognition impairment, this is sort of an emerging role in which the role of ADT leading to decreases in testosterone, and FSH may have some role in cognition and cognitive impairment. So the whole concept of is it just low testosterone that's leading to these abnormalities, or is low testosterone as a result of ADT being modulated through some of the actions, the multitude of actions of FSH? In terms of other cancers, FSH has been shown to have a role in breast cancer. Breast cancer cell lines show de novo FSH synthesis in breast tissue. There's a very interesting correlation between patients with premenopausal breast cancer in terms of their ambient levels of circulating FSH, not in postmenopausal women in which the FSH levels are high, that basically correlate to the incidence of breast cancer. And very interesting, although agonist therapy is sometimes used in breast cancer with a 41% response in patients receiving goserelin, FSH occurs in these patients as would be expected, and tamoxifen can prevent this FSH escape and also be associated with clinically meaningful responses. So there's just a lot of information relating to the potential role of FSH in breast cancer, as well as in ovarian cancer, where receptors are present in ovarian cells, and FSH stimulates in vitro ovarian cancer cell growth. LHRH agonist therapy can inhibit the growth of some ovarian cancer cell lines, and agonist therapy can lead to partial remission and stable disease in advanced ovarian cancer patients, usually at the same time that the FSH levels have actually fallen from their peak levels. And the final thing that I wanted to mention in terms of sort of the very interesting preclinical goes back to the question. This is a paper just published in looking at the growth of glioblastoma multiforme. And it turns out that so-called brain tumor stem cells are causing the recurrence of glioblastomas. And these stem cells are affected by epigenetic factors, including a group of regulators that are called the ING regulators. And these ING regulators, of which there are 5 or 6, are actually inhibitors of a growth family of epigenetic regulators that work through histone acetylase and histone deacetylase complexes. So it's a novel group of growth family regulators that seem to be involved in causing stemness in patients with glioblastoma. And the ING requires activation of calcium channels and FSH pathway genes to increase the effect of increasing the actual number of brain cancer stem cells. So it's a completely novel way of looking at tumor repopulation, especially in a localized place such as the brain, in which FSH may have some role. And the citation of there is, this paper was just published within the last 10 days. So what's the human experience that can help try to shed some light? And again, we have not done as much as we should on this, but let me share with you one study that we were involved with several years ago on looking at the role of potentially modulating FSH in 2 populations of patients. These are men with, at that time we called them hormonally refractory men. These are men with what we would call today castrate-resistant metastatic prostate cancer. And these data were done by Thomas Beer at the University of Oregon. And the study was basically looking at patients that we had previous orchiectomy or GnRH therapy in which their ambient levels of FSH were identified at presentation. And these patients were then treated with doses of the conventional doses of the GnRH antagonist Abarelix. And we can see that the levels of FSH really sky high in the orchiectomy patients at the time of entry to that study at levels of 45 compared to the 5 to 6 level microinternational units of FSH in the 5 to 6 level in the LHRH treated population. We can see that there was a dramatic and prompt reduction of FSH following the GnRH antagonist in the orchiectomized versus the GnRH previously treated patients. And if one takes a look at PSA response using conventional criteria, in the prior orchiectomized patients, we had a 31% response rate compared to 5% in the LHRH population, and the progression-free survival at 6 months was basically 38% versus 10%. These data have been sort of looked at in other populations, especially with Abarelix. So there's some information to suggest that in patients with high levels of ambient FSH following the development of castrate-resistant prostate cancer, further reduction of FSH may play a potential role in further affecting some biochemical remissions. And here's the progression-free survival in the orchiectomized population versus the GnRH population. So I think in summary, what I've tried to do is provide a very balanced view of the role of FSH, both pros and cons. It's been around a long time. We finally have something that can modulate its levels. So I think in summary, FSH role extends beyond proliferation of prostate cancer, but also is a potentially very important modulator of androgen deprivation side effects. There are differences in FSH kinetics between varying androgen deprivation therapies, and could some longer-term improvements with GnRH antagonists be mediated via FSH? So with that, I thank you very much for your attention and look forward to the discussion.